স্যার আমরা এখন স্টার্ট করতে পারি। বদিউজ্জামান স্যার আমরা শুরু করতে পারি।
ওকে ঠিক আছে। Assalamu alaikum. Very good evening, everyone. It's a great pleasure to welcome you all in another session of NHF cardiac course on cardiac emergencies. Today we will discuss on a narrow complex tachycardia in cardiac emergencies. As we all know, patients with narrow complex tachycardia are not uncommon in our cardiac emergencies, and it is very crucial to recognize the correct nature of the tachycardia and give the patient the correct treatment. Otherwise, sometimes it may be counterproductive. So today we will discuss on various issues about narrow complex tachycardia, how to evaluate, how to recognize, and how to treat them. And we have with us Professor Mohammad Mohsen Hussain, Professor of Cardiology, National Institute of Cardiovascular Disease. He is one of the leading experts in the cardiac electrophysiology in our country. He's a well-experienced operator and very excellent teacher in this field. Welcome, Professor Mohsen Hussain. It's a great pleasure to have you with us. Thank you for joining us. And we have also two speakers with us. First speaker is Dr. Mohammad Shamim Chaudhry, Registered National Heart Foundation Hospital Research Institute, and Dr. Mir Nesaruddin Ahmed, Associate Professor and Senior Consultant of Cardiology, will give his talk next. So before I start, may I request our Chief Consultant, Professor Fazilatunisa Malik, to make some opening remarks if she's present. Madam Achinki? Madam Kache?
Madam ব্যস্ত।
Okay, then if because Madam is not here present, so may I invite for our first speaker, Dr. Shamim Chaudhry, or may I request our panel expert panelist, Professor Mohammad Mohsen Hussain, to make some few opening remarks. Then we will start our session. Professor Mohsen, will you make few opening remarks before we start?
Thank you very much for inviting me to this scientific session. I'll be very happy join your. If any help with me times, I will be ready to help them in exam related question. So this course mainly for the MD students. So if they need any kind of academic help or any ECG interpretation or related to the tachycardia or narrow complex tachycardia, wide complex tachycardia, I will be happy to answer their question. Thank you very much for your kind introduction, sir.
Thank you very much. Okay, so I invite our first speaker, Dr. Shamim Chaudhry, to present his talk. Dr. Shamim Chaudhry, please go on.
Assalamu alaikum. Honorable Chairperson, panel of expert, distinguished audience, and my dear students. My today's topic of presentation is the narrow complex tachycardia. My part will be to discuss on the physiology and the mechanism of the narrow complex tachycardia. By definition, narrow complex tachycardia indicates the presence of the fast heart rate of 100 beats per minute associated with the narrow QRS complex measuring less than 120 milliseconds. Broadly, narrow complex tachycardia can be classified as a sinus tachycardia, supraventricular tachycardia, atrial flutter, and atrial fibrillation. In the broad heading of supraventricular tachycardia, there are some other tachycardias like the AVNRT, AVRT, automatic atrial tachycardias. Later, this part will be discussed by my next presenter. . Now, regarding the sinus tachycardia, any rhythm arising from the sinus node in which the rate of impulse exceeds 100 beats per minute is the sinus tachycardia. There are two varieties, that is physiologic sinus tachycardia and inappropriate sinus tachycardia. In physiologic sinus tachycardia, there will be increased sinus rate which related to the exercise and other situations that increase sympathetic tone. In case of inappropriate sinus tachycardia, sinus heart rate will be more than 100 beats per minute at rest with mean 24-hour heart rate more than 90 beats per minute, not due to any appropriate physiological response or primary cause such as hyperthyroidism or anemia. Now, the AV node has two input pathway, that is the fast pathway and the slow pathway. Fast pathway located near the apex of the Koch triangle, and the slow pathway, it is the along the complex AV node tissue, and it is thus situated in the septal margin of the tricuspid annulus at the level of or superior to the coronary sinus. Now, the most common is the sinus among the narrow complex tachycardia is the supraventricular tachycardia. Supraventricular tachycardia is the narrow complex tachycardia originating outside the sinus node but above the bifurcation of the bundle of His with a rate that exceeds 100 beats per minute. Usually, the supraventricular tachycardia, the impulse conducts through the AV node from atria to the ventricles. That's why the QRS complex is the narrow. And in case of ventricular tachycardia, there is ventricular atrial impulse propagation, so the complexes will be wide. However, according to the mechanism, narrow complex tachycardia can be classified by the three mechanisms. One is the re-entry, another one is enhanced automaticity, and the triggered activity. The most commonly is the re-entry tachycardia, that is around from the 90% of the narrow complex tachycardia. Here is the abnormality is in the impulse conduction, and enhanced automaticity and triggered activity are the very less in frequency. In case of enhanced automaticity, the impulse problem is in the impulse initiations. Here, the cells with automatic properties become the dominant pacemaker, and in case of triggered activity, early or late after depolarization are present. Usually, re-entry are found in case of structurally normal hearts, and in enhanced automaticity is found usually with metabolic or pulmonary disorders, and triggered activity is found with some drug toxicity or post-cardiac patients. Common examples of the re-entry are the AVNRT, AVRT, SRT, and interatrial re-entry. And common example of the automaticity is the atrial tachycardia. And this is the picture of the three mechanisms. The re-entry, there is a slow and the fast pathway, and the enhanced automaticity where there is a slow diastolic depolarization phase, and in case of triggered activity there is the early after depolarizations and late after depolarizations. The supraventricular tachycardia due to re-entry can be classified into atrioventricular nodal re-entrant tachycardia, atrioventricular reciprocating tachycardia, sinoatrial re-entrant tachycardia, and intra-atrial re-entrant tachycardia. However, AVNRT is the most commonest one, followed by the AVRT. This is the diagram showing the re-entry, basic mechanism of the re-entry, where the fast pathway and the slow pathway are conducting. By the slow pathway that conducts the impulse anterogradiently from the atrium to ventricle, so the QRS complex is narrow because the impulse follows the normal AV conduction system. However, in case of fast pathway, the conducts impulse retrogradely to the atria because of the atria are activated from below upwards, so the P waves will be inverted in lead 2, 3, and ABF. In typical AVNRT and atypical AVNRT is the classification very commonly used. The typical AVNRT is the impulse conducted anterogradely to the ventricles through the slow pathway and retrogradely to the atria through the fast pathway. That is the slow fast circuit. In case of atypical AVNRT, the impulse conducted anterogradely to the ventricles through the fast pathway and retrogradely to the atria through the slow pathway. There is a fast and slow circuit. This is the pathophysiology of the AVNRT, wherein premature atrial impulse enters the slow pathway but blocked at the fast pathway. From the slow pathway, it conducted to the ventricles. The ventricles are activated synchronously, followed by the impulse conducted retrogradely through the fast pathway, and impulse activates the atria retrogradely and re-enters the circuit. And this is how the AVNRT happens, and there will be the QRS complex will be narrow. In case of AVRT, it is the second most common, approximately 30% of all SVT. Here there will be a bypass tract that connects the atria directly to the ventricles. It is of two varieties, that is orthodromic AVRT and antidromic AVRT. In case of orthodromic AVRT, there will be QRS complexes will be narrow. In case of antidromic AVRT, QRS complexes will be wide. QRS complexes are narrow since the ventricles are activated through the AV node in case of orthodromic AVRT. In case of antidromic AVRT, the impulse is activated through the bypass tract. So the conduction goes from ventricle to the atria through the AV nodal normal tract. So the QRS complexes will be wide. In case of orthodromic AVRT, premature complex enters the AV node but not the bypass tract. The impulse conducted through the AV node slowly. Both the ventricle activated synchronously. Then impulse enters the bypass tract and activate the atria retrogradely and re-enters the AV node. That is why the QRS complexes are the narrow. But in case of antidromic AVRT, bypass tract has a short refractory period and impulse conducted through the bypass tract to the ventricles and retrogradely through the AV node conducts impulse from the ventricle to the atria. So the complexes are the wide. Another example is the WPW syndrome, that is Wolff-Parkinson-White syndrome. WPW syndrome is a clinical entity characterized by the pre-excitation of the ventricles with symptoms of paroxysmal tachycardia. Here there is also the bypass tract is present. It is a classical example of the antidromic AVRT. In WPW syndrome, there will be bypass tract and ventricle is activated prematurely through the bypass tract. So there will be the PR interval will be shortened and there will be initial slurring of the QRS as the ventricles are activated prematurely. Then followed by impulse delayed at the AV node and impulse conducted through the AV node to the ventricles as like normal impulse. So there will be the slurring of the QRS and the widening of the QRS. And this is the diagram showing the localization of the accessory pathway or bypass tract. Usually, most commonly, 60 to 70% pathway left in the left ventricular free wall, and next there will be the posterior-septal or anterior-septal pathway that will be either left or right, followed by the right ventricular free wall. This will be how this pathway can be identified. It will be discussed later by next presenter. Now the causes of the ventricular pre-excitation, most common fiber, that is the bundle of Kent, that is the responsible for the WPW syndrome, where there will be bypass tract that connects the atrium directly to the ventricle. However, there will be other tract like Maham fibers, where there will be different connections like nodoventricular, hesioventricular, fasciculoventricular, or atriohesian connection. And another one is the superconducting AV node. In case of nodoventricular, a bypass tract connect the AV node directly to the ventricle. In case of hesioventricular, bypass tract connect the His bundle to the ventricle. In case of fasciculoventricular, bypass tract connect the right ventricle or left bundle branch to the fascicle directly to the ventricle. In case of atriohesian, the atria directly connect to the bundle of His. This is the diagram showing the common pathway, that is a common bundle of Kent in case of WPW syndrome. These are the Maham fibers, that is the nodoventricular, fasciculoventricular, and this is the atriohesian, there is a connection between the atria and bundle of His. And this is the superconducting AV node, where there will be short PR interval, but the QRS complex will be normal, and there will be no delta wave that is found in the Lowen-Gannon Levine syndrome. And these are some rare supraventricular tachycardia that is altered automaticity. Common example is the atrial tachycardia, where there will be phase 4 slow depolarization and firing automatically when it reaches the threshold. That is done by the automatic pacemaker cells. And another form is the triggered activity, where there is some presence of after depolarization, which is found in case of some drug toxicity like digitalis or calcium channel blockers or post-cardiac surgery patients. Now, the common atrial fibrillation in where there will be reentrant arrhythmia, where there will be multiple independent wavelets in the atria. These reentrant wavelets can be precipitated by the ectopic impulse originating from the pulmonary vein as well as other large vein draining into the atria. And atrial flutter is another supraventricular arrhythmia, which is due to re-entry within the atria. There are common two types, classical and the reverse type. In case of classical atrial flutter, the flutter waves activates it comes through the lateral side of the right atrium and goes through AV node in the interatrial septum towards upwards. So there will be inverted flutter waves in lead 2. And in case of reverse atypical atrial flutter, the impulse goes from the septal pathway and goes upwards towards the lateral side of the right atrium. So there will be upright flutter waves in lead 2. Thank you all for patient hearing. That's from my part.
Thank you, Dr. Shannon Chaudhary, for your nice presentation. So I think question answer session will be after we finish our second lecture. So I invite Dr. Mir Naseeruddin Ahmad, Asset Professor and Senior Consultant, to deliver his talk. Dr. Mir Naseeruddin Ahmad.
Thank you, sir. Honorable moderators, distinguished faculties, including our guest faculties, and my colleagues and attendees. Just I start with a short case note. It is a 30-year-old lady suddenly developed very rapid palpitation and chest pain while working with her laptop. She immediately rushed to the emergency department of her nearest hospital. On examination, her pulse was more than 150 beats per minute. Blood pressure was 90 by 60 millimeter mercury, and she was just feeling of appendix dome. Her ECG was done and showed the narrow complex tachycardia. And let us see what is this tachycardia. So what is the narrow complex tachycardia? Already Shami has told very nicely. That is less than 120 milliseconds, which reflect activation of the ventricles via the normal His Parkinson system. And usually arrhythmia originates above the His bundle, and sometimes the site of origin may be in the sinus node or in the atria or atrioventricular node or His bundle, and some combination of the site. And supraventricular tachycardia sometimes may be concurrent with wide bundle bunch, wide complex tachycardia, despite origin from the supraventricular cardia also, is because due to a pre-existing bundle branch block or interventricular conduction delay, or sometimes maybe there may be due to pre-existing bypass tract. So it's a heterogeneous group of arrhythmia, but variable underlying, though it has variable underlying mechanism, but basically the treatment approach is very similar, and it usually affects all age groups. So why should we care about the supraventricular tachycardia or narrow complex tachycardia? Due to its morbidity and mortality, patients may discomfort and anxiety while carrying this tachycardia, and sometimes may have syncopal attack, usually around 15%, and the risk of sudden cardiac death is rare, but in presence of accessory pathway due to degeneration into ventricular fibrillation, patient may have sudden death also. And sometimes if the complication due to tachycardia-mediated cardiomyopathy, patient may develop LV dysfunction as well. And how will I approach this classification of the, just wait. If you look at the clinical behavior, it may be paroxysmal, may be persistent or permanent. Sometimes it may be cessant, that is persist for the days or weeks, and will sustain or not sustain. And something may be chronic or repetitive. And according to mechanism, it may be ectopic or maybe automatic or reentrant or maybe orthotopic is due to anterogate conduction through the normal pathway, or it may be antidromic if there is retrograde conduction, anterogate conduction through the bypass tract. And sometimes with the ECG appearance, it may be narrow complex or it may be wide complex. And according to location, it may be sinus or atrial or epineural junction lattice. Now, what's from the sinuatrial? Already Swami has told the inappropriate sinus tachycardia is one of the variety which arise from the sinuatrial node, and another is the sinus node re-entry tachycardia. And from atrial source, it may be unifocal atrial tachycardia, or it may be multifocal atrial tachycardia, and sometimes atrial fibrillation with rapid ventricular response and atrial flutter with rapid ventricular response. But in case of if there is no rapid ventricular response, in that case, atrial flutter or fibrillation will not be classified as supraventricular tachycardia. On the other hand, if we look at the atrioventricular source, it may be AVN artery, that is classical supraventricular tachycardia, or it may be AVRT, that is atrioventricular re-entry tachycardia, which may be visible or concealed pathway, including WPW syndrome, and that may be permanent, that is PJRT, that is permanent junctional re-entry tachycardia, which usually most common in the infant and children at incessant form. And if we look at the classification, the narrow or wide complex tachycardia, narrow complex tachycardia, that it may be regular or it may be irregular. If it is regular, that is sinus tachycardia, or it may be atrioventricular nodal re-entry tachycardia, or it may be atrioventricular re-entry tachycardia, atrial tachycardia, or junctional tachycardia, or maybe atrial flutter with 1:1 conduction. If it is irregular, in that case, it could be atrial fibrillation, atrial flutter with variable block, or maybe multifocal atrial tachycardia. If that is wide complex tachycardia, in that case, it may be again, it may be regular or irregular. If it is regular, in that case, with the ventricular tachycardia or supraventricular tachycardia with aberrancy. If it is irregular, it may be polymorphic VT or be atrial fibrillation with aberrancy or atrial fibrillation with WPW syndrome. So, if we look at this flow chart, that is again narrow QRS complex, this may be regular. The visible P wave, there is no visible P wave. In that case, it may be AVNRT, or again, if it is atrial rate, if atrial rate is the visible P wave, that is yes. In that case, atrial rate greater than ventricular rate, definitely it may be atrial flutter or atrial tachycardia, or if there is atrial rate no, not the ventricular rate, in that case analyze RP interval. If RP interval short, in that case it is AVNRT. If RP interval long, in that case we can think about AVRT or atypical AVNRT or atrial tachycardia, or sometimes it may be a long RP tachycardia, that is atrial tachycardia or permanent junctional re-entry tachycardia or atypical AVNRT. So we can see the four possible groups. That is narrow complex, regular P wave, it may be AVNRT, AVRT, atrial tachycardia, junctional tachycardia, or atrial flutter with 1:1 conduction. Or it may be narrow complex with irregular no P wave. In that case, atrial fibrillation, a flutter with variable block, or maybe multifocal atrial tachycardia. If it is a wide QRS complex, regular but no P wave, in that case ventricular tachycardia, or maybe supraventricular tachycardia with aberrancy. Or the wide complex tachycardia regular, no P wave. Hello? In that case, it may be polymorphic VT or atrial fibrillation with aberrancy or atrial fibrillation with WPW syndrome. So if we look at the time from the ventricular activation to subsequent atrial activation, or time from atrial activation to subsequent ventricular activation, it may be long RP or short RP tachycardia as well. There's a look at the PR-RP interval. The short RP, that is short RR interval, that is RP less than 50% of the RR interval. In that case, it may be classical AVNRT again or sinus tachycardia or junctional tachycardia. If long RP, RP, that is RP interval, the more than 50% of the RR interval, that is atypical AVNRT or inappropriate sinus tachycardia or sinus node re-entry tachycardia or atypical atrial tachycardia. This is also, and again, the regular diagnosis also of short RP tachycardia, already told. The same long RP tachycardia. This is the graphical presentation. The retrograde P wave, there is a pseudo S wave in the inferior lead, which is the classical variety for the supraventricular tachycardia, that is a VNRT, and prime R or pseudo R in the V1 is also the one the sign of supraventricular tachycardia. There is a retrograde P wave, retrograde R wave, retrograde same. So I can skip this slide. So consider under PSBT, it can be impossible to differentiate sometimes with the ECG. So treatment generally the same though. So these are the different forms of tachycardia. That is multifocal atrial tachycardia. That is atrial flutter with variable AV block. There is atrial flutter. That is atrial flutter. And what is the regular SBT in the adult? If you look at the epidemiology, there is 90% is almost from reentrant tachycardia and 10% only from non-reentrant. And 60% have AV nodal dependent tachycardia, that is AV node reentrant tachycardia, and 30% only orthotomic respiratory tachycardia, that is ORT, and 10% at atrial tachycardia. Only 2 to 5% involve the WPW syndrome only. If you look at the symptoms, what are the classical symptoms for the SBT or sort of narrow complex tachycardia? That is, patient may have palpitation, patient may feel discomfort, lightheadedness, dyspnea, fatigue, presyncope, sometimes polyuria due to release of atrial natriuretic peptide, and sometimes patient may develop syncope, though it is very rare in case of tachycardia. And we can also clue from symptoms that is either is regular or irregular, that is previously deployment, or it may be atrial flutter or multiple tachycardia, or it may be sudden onset and offset. It may be AV-narrative. There is no clear precipitating factor in that case, or it may be gradual onset and symptoms that get more rapid over time and may persist for long. That is particularly mainly for that is from atrial tachycardia. These are the another form, and mechanism already told by the that is all the thing. And how will you diagnose this ECG? The ECG is the main cornerstone, by observing the zones of transition from clues and its mechanism, onset, termination, and slowing sometimes by using AV nodal block and pre-existing bundle branch block or developing a bundle branch block due to during initiating tachycardia, we can diagnose easily. And already told by the Dr. Shami, the most common PSBT, more than 60% cases due to presence of AV nodal dual physiology and active ventricular tachycardia due to accessory pathway. AVNRT, and what's AVNRT? That is helpful ECG diagnosis for pseudo RV1 and pseudo S in the 2-3 AVF, and sometimes we can see that this ST-RP, if RP more than 100 millisecond and STD patient more than 2 or equivalent 2 millimeter, in that case we can suggest the AVRT. That is already discussed by the Dr. Shami. There is a AVNRT, same. There is retrograde or inverted in the 2-3 ABF, and sometimes due to simultaneous activation of the atrium and ventricle, it may be due to most common presentation of the AVNRT 60%. And if not synchronized, in that case, C2SO in the inferior lead, almost in the V or in the V1, that is almost 30% cases. And AVRT same, we can see electrical alternates, that the amplitude of the QRS complex varies by 5 millimeter alternatively. And rate-related bundle branch block occurring at the rate of tachycardia is decreasing, then the bypass track is on the same side. Then another form of the narrow complex tachycardia, that is atrial tachycardia, they're almost due to increased automaticity and maybe common in the right atrial focus, and maybe re-entered, particularly in patient with previous atrial scar, that is from the bypass, that is from cardiac surgery or CABG or congenital repair of the patient, and often associated with underlying cardiac disease. And again, usually it rate 100 to 250 beat per minute, and usually does not require the AV node, that the AV node independent tachycardia, and PA morphology is different, that is than the sinus, and PR interval is more than 120 milliseconds, differentiated from the junctional tachycardia. And atrial tachycardia, that is PO upright, if it is PO upright, the B1 and negative in the EABL, that is constitute the left atrial focus. If POA negative in V1 and upright AVL constitute the right atrial focus, and addition sometimes may help to diagnose the AV block if AV block occurs and continued arrhythmia likely atrial tachycardia. And sometimes MAT usually origin from 3 or more, and rate is 100 beat per minute, and maybe as high as 250 beat per minute, and it is irregular rhythm with varying PP or RI interval and isoelectric baseline between POFs. There is no flutter wave, and absence of single dominant atrial pacemaker, and just sinus node. And here is the inverted flutter wave 2-3 ABF, and with atrial rate around 300 millimeter beat per minute, and positive flutter wave in P1 resembling P waves, and the degree of AV block, that is 2:1 or sometimes maybe 4:1, or R interval multiple of the R interval, that is multiple of the RR period. Another form of pre-excitation, that is classical WPW or Wolff-Parkinson-White syndrome. There's a short PR interval. Keywords usually more than 100 millisecond, and delta with some leads. So if there is a frank on the pathway, or LGL syndrome, there is a short PR interval, but no delta over here. There is the classical WPW pattern, that is pre-excitation variant without any arrhythmia. It just there's two types of the active pathway that's already told by the Dr. Shamim, and WPW with syndrome with that is with SBT, it may be orthotomic, and most of the time, almost 90 to 95% cases usually orthotomic, and rest of the cases are usually antidromic, that is conduction, integrate conduction through the bypass tract and retrograde conduction through the through the normal his parking system. That's why QRS coverage become wide, and very dangerous patient may develop if the rate is more than 250, especially the patient having atrial fibrillation, patient will degenerate into ventricular fibrillation. And in that case, what that is avoid, almost try to avoid abdominal blockers and use usually procainamide, or if the patient hemodynamic unstable, in that case you can cardiovert. And WPW syndrome with WPW with atrial fibrillation, same orthopedic makes up to 90-98%. Yeah, and it's common, almost around 30%, and patient usually potentially life-threatening. Active pathway having usually short effective period with integrated conduction near 1:1, and which degenerative ventricular fibrillation, and usually incidence around less than 1% incidence of sudden cardiac death. And but don't, in that case, you don't use, if the QRS is wide, irregular, in that case, don't use any abdominal blocking drug. Channels all impulse down the active pathway, and the risk patient may develop ventricular fibrillation. Use usually procainamide or cardioversion. And treatment for stable patients, we can think about a cardioversion of procainamide or atrial fibrillation bundles, normal as the neurocomplex. And in that case, in unstable patient, we can use cardioversion directly. And what are the predictors for sudden cardiac death in case of WPW? The shortest pre-excited RR interval during atrial fibrillation, there's the rate more than 250 beats per minute, and history of symptomatic tachycardia, and may have multiple accessory pathway, and sometimes many patients have Epstein anomaly also. And what the acute treatment in case of SBT, especially during the diagnosis, may have during resting ECG or during sinus ECG, no delay therapy of the mechanism of SBT is not known, and perform carotid sinus pressure or give 6 mg bolus adenosine. In case of severe hemodynamic compromise, synchronized cardioversion may be given immediately. And sometimes we can use IV adenosine to see the nature of the tachycardia also. And if the patient is hemodynamic stable, according to hemodynamic status of the patient, if the patient is stable, narrow complex, is RR regular, you can use physiological and pharmacological maneuver, and that in that if it is refractory, then we go to the second part, and if the UPS complex is wide, the vagal, again we can use physiological and pharmacological maneuver, or sometimes you can use digoxin, verapamil. Usually here is a contact, especially in case of wide QRS complex tachycardia. And if the patient is hemodynamic unstable, the direct cardioversion. And refractory cases, especially narrow complex, IV adenosine, procainamide, amiodarone, or direct cardioversion. And in case of wide QRS, arterial pacing or direct cardioversion. If the patient is also same, almost usually depends on the chest. Patient may have chest pain, hypertension, or altered level of consciousness, or pure perfusion, or patient may develop congestive heart failure. Almost 70% patient may with tachyarrhythmia, patient may complain chest pain, but it is not due to having myocardial infarction. Unstable patient usually means cardioversion or defibrillator, but many times may try, we can try medication as well. So narrow complex, regular, no POF. In that case, beta blocker, abdominal blocking drug, adenosine, verapamil, we can use. For unstable patient, we can use direct cardioversion. Or if narrow complex, irregular, no POF, in that case, aims to slow the, only target is to slow the ventricular rate, not convert, and we can use calcium channel blocker, that is digoxin, deltazem, or digoxin, or beta blocker, or amiodarone. And in case of unstable patients, we can use deltazem or dupapin, or difficult rhythm to treat. In that case, you know, 48 hours of the embolectomy, so you have to use anticoagulants also. Quite complex, regular, no POFs in that case. If the patient is young, in that case, we can use adenosine or procainamide amiodarone, and same all unstable patient in the direct cardiac version. And irregular, wide complex, no POFs in that case. Safest to when we confirm whether patient having narrow complex tachycardia, there is a duty supraventricular tachycardia or ventricular tachycardia. In that case, safest to assume the patient their ventricular rhythm, they manage accordingly as the ventricular tachycardia. And regarding the cardiac version, first sedate the patient by midazolam, or we can use fentanyl. And energy level we can use in case of PSVT 50 joules in atrial fibrillation to 200 joule, atrial flutter to 25 to 50 joules. And in case of orthotopic tachycardia, in that case 50 joules, or narrow complex 50 to 100 joules we can use. And regarding adenosine, it is coronary vasodilator and reflex catecholamine release symptomatic rise, and half-life is less than 10 seconds, and duration of only 30 to 40 seconds. So we can usually safely the adenosine. And some acute treatment, somebody is an unstable patient, direct cardioversion, unstable and stable patient, that we can use physiological maneuver, the vagal maneuver, or you can use different types of drugs as well. And some adverse effect, almost 75% patient may have some sorts of adverse effect, that is maybe patient have flushing, dizziness, dyspnea, chest pain, feelings, impending doom or anything else. And sometimes it may cause the proarrhythmic also. And in that case, if we consider take is about the proarrhythmic drug, it may cause atrial fibrillation, or which may degenerate ventricular fibrillation, and may cause transient sinus arrest or asystole or tertiary poiesis as well. Regarding adenosine, we have to consider care regarding the other patient having bronchospastic disease, adenosine, which may precede bronchial asthma, and given very rapidly within 1 to 2 seconds. Sometimes we use peripheral bed. In that case, we have to uplift the arm, and maximum dose we can use 30 milligram in 3 shots. That is first 6, then 12, then again 12. And it's usually terminate the AV nerve, and sometimes it convert atrial flutter into 2:1 AV block. And sometimes we can use pill in the pocket approach, especially when the patient recurrence are very infrequent, but sustained well tolerated hemodynamically patient, and patient who have had only single episode of SBT, and we can use flecainide or verapamil and propafenone as well. And 80% case interrupted within the combination of calcium channel blocker and beta blocker in 2 hours. And who needs electrophysiology study, especially patient having tachycardia with QRS complex, SBT with syncope or severe symptoms, and intolerance to drug or resistant to drugs, or patient may do not take the drug regularly. In that case, patient sent for EP study, and pre-excitation with high risk characteristics, and patient preference to be free of drug therapy. In that case, we should send the patient for EP study and if need ablation as well. And regarding the carotid sinus pressure, it is sometimes, previously it was called carotid sinus masses, but nowadays it is called carotid sinus pressure. It is before giving the pressure, you have to care about the carotid body, whether presence or not, and pressure applied over the carotid sinus for 5 to 10 seconds, and simultaneously ECG recording, and in that case, and simultaneous pressure not to be applied on both sides, and alternate maneuver or Valsalva or gag reflex or ice water pouring we can use. And it is usually due to stimulation of the baroreceptor reflex and vagal tone, which is reflect affecting the medulla and modulate the action of the SN node and AV node. And what the control of SBT? How can we control the SBT? In case we can use memory stabilizing drug, that is antiarrhythmic drug. We can give catheter ablation, sometimes give to surgery, or sometimes in rare cases we can use anti-tachycardia basic. And supraventricular tachycardia situation in which refer to the cardiologist or electrophysiologist. Medication are not controlling symptoms. In that case, we should send the patient to the electrophysiologist, and patient cannot tolerate medication or no longer wish to use them, or patient has worsening symptoms or is becoming hemodynamically unstable, and patient high risk of patient, especially aircraft pilot or truck driver or bus driver, that is a commercial vehicle driver, or heavy equipment operators, or certain high risk or recreational activities, that is rock climbing, scuba diving, etc. And sometimes physicians are uncomfortable with uncertain about management or initial diagnosis, and pre-excitation is present on electrocardiographically or if atrial reciprocal tachycardia is suspected, and sometimes supraventricular tachycardia is accompanied by syncope with white QRS complex is present. In that case, patient should send for electrophysiological study to the electrophysiologist. And in case of WBW syndrome, symptomatic concealed or manifested and evidence of pre-excitation on sinus rhythm, send the patient for catheter ablation directly. So in key take-home points, that is, PSBT is a heterogeneous group of arrhythmias, and patient usually gets cardioverted if his hemodynamic are unstable, or adenosine is the treatment of choice for stable PSBT patients, and avoid beta blockers in any white QRS complex tachycardia or irregular rhythm. And WBW has a small but definite risk of sudden cardiac death, and ablation technique are curative in more than 90% patients with severe or recurrent arrhythmias. And thank you all. That's it. So thank you for patience, Harry.
Thank you.
Now the session for questions.
Thank you, Dr. Mir Nesaruddin Ahmed, for your excellent talk. So now the session is open for discussion. May I request first Professor Mohsen Hussain to make some initial comments about the presentation, then we'll have some question answer session. Professor Mohammad Mohsen Hussain.
Very much. Dr. Shamim, for your nice deliberation regarding pathophysiology and mechanism of complex tachycardia, and Nesar Bhai for clinical manifestation and regarding management of supraventricular tachycardia. They have touched from all the what tachycardia very broad, but clinical and I have in the MD cardiology or not there laboratory.
Mohsen bhai,
So
আপনার your sound আসছে আপনার আপনি if you close your ভিডিওটা অফ করে দিলে আমার সাউন্ডটা ভালো আসবে। আমার সাউন্ডটা ব্রেক করে আসছে ভিডিওটা অফ করে কথা বললে বেটার হবে। এবার বলেন জি প্লিজ।
Nesar Bhai has talked all spectrum of supraventricular tachycardia, complex tachycardia, regarding symptoms, management, classification, all types of tachycardia, and differentiation of narrow complex tachycardia, the wide complex tachycardia. So in exam, some beginning with the ECG, what is this diagnosis? Go through the next. Manage this. So it is frequently encountered the exam in this narrow area, the exam viva, the ECG portion of the so it is, they have asked all the all through the pathophysiology, clinical picture, and medical management and curative treatment of the. Thank you very much for both the speaker.
Thank you, Professor Mohsen Hussain. There was a question in the chat box. Is why verapamil is contraindicated in pre-excitation? Who is going to answer it? Why verapamil is contraindicated in pre-excitation? Dr. Mir Nesaruddin Ahmed or Dr. Shamim, who will answer? Ask Mir Nesaruddin Ahmed.
So verapamil usually, in case of pre-excitation, the impulse conducts through the bypass tract and comes to the retrogradely from the ventricle to the atria. In case of verapamil, if it blocks the AV nodal pathway, so there will be some sorts of re-entrant will be more excited, and there will be some ventricular fibrillation, risk of ventricular fibrillation or exacerbation of the tachycardia.
Dr. Ashok Datta, are you happy with the answer? Dr. Ashok? শোনা যাচ্ছে না তোমাকে।
Yes. Thank you, sir. So any opinion from Professor Mohsen or Dr. Nesaruddin Ahmed? regarding verapamil in WPW. This is common question asked in the exam. Digoxin, verapamil, in some books written like this, should not be given in WPW. But I think digoxin is contraindicated, but why verapamil is contraindicated? Because if the patient is not in atrial fibrillation, only in pre-excitation with SBT, pre-excitation with normal sinus rhythm. So that will happen if I give verapamil. AV conduction will be delayed, but accessory pathway conduction, anyhow, AV conduction if delayed, that will also automatically reduce the SBT rate. AV blocking adenosine we are giving to block the AV node, not to block the accessory pathway. So that is terminating the SBT. So if verapamil block the AV node, that will also terminate the SBT. Whether it is SBT with that is called accessory pathway or SBT with a nodal pathway.
Dada,
So
can I add
before-
something?
Any answer?
Sir.
Please.
If there is white QRS and atrial fibrillation, don't use any abineural blocking drug. If we use abineural blocking drug, in that case, it can increase the sport conduction that is directly from atrial to ventricle through the accessory pathway. In that case, patient may develop atrial fibrillation with rapid ventricular response and which may degenerate ventricular fibrillation, and it could be life-threatening for the patient. But if narrow complex, we can use abineural blocking drug. In that case, safely we can use narrow
Any comment
complex,
from-
no
Yes,
pre-excitation.
Any comment from Professor Mohsin bhai?
Professor Mohsen, verapamil, can you use verapamil in a patient with pre-excitation narrow complex tachycardia?
Because the basic concept Nesar was told, the WBW or pre-excitation with atrial fibrillation, non-atrial fibrillation, we cannot use any sorts of AV blocking agent. It will block the AV node and it will exacerbate the conduction through the accessory pathway. So patient will develop atrial fibrillation through the ventricular fibrillation and patient will die. So if the patient has a regular and narrow complex tachycardia without atrial fibrillation, so we can safely use verapamil in the long term. There is no contraindication, even in toxin. So
Yeah.
it is really so only atrial fibrillation, non-atrial fibrillation, we cannot use AV blocking like verapamil, digoxin. So,
Actually, previously, when
Any
I know about 2 decades back, when adenosine was not available in Bangladesh, only drug to treat pre-excitation syndrome in narrow complex tachycardia was verapamil. So verapamil was widely used to treat in pre-excitation syndrome in narrow complex tachycardia before adenosine was available in Bangladesh. So
Sir, I
I
have
think,
one
only
point.
only if there is atrial fibrillation, in that case, it's drug using which
This is
blocks
atrial
AV
fibrillation.
node.
What about the white complex tachycardia? Suppose it is SBT with aberrant conduction. So verapamil is contraindicated here also.
No, if there is aberrant conduction, if there is pre-existing bundle plus block, we can use verapamil.
But
That
if
is-
there is white
But you have to
complex,
sure, yeah, you have to sure. That is, it is a narrow, that is white complex, but this is SBT. This is not BT.
পেশেন্টের কাছে যদি আগের কোনো ইসিজি থাকে যেখানে তার 12 ইসিজিতে ব্লকেজ আছে ইন্টারভেন্ট্রিকুলার ব্লকেজ, তারপর সেই এসবিটি আসলো, সেক্ষেত্রে আমি শিওর যে সেখানে দেওয়া যেতে পারে। আরেকটা প্রশ্ন আসছে এখানে, আদার কোশ্চেন, হোয়াট আর দ্য ড্রাগস দ্যাট ইজ কন্ট্রাইন্ডিকেটেড ইন WPW সিনড্রোম? এরকম কি কোনো ড্রাগ আছে? হোয়াট আর দ্য ড্রাগস কন্ট্রাইন্ডিকেটেড ইন WPW সিনড্রোম? Is anybody to answer?
Professor Mohsin, drugs contraindicated in WPW, commonly asked question in the exam. As
Mainly-
you are an examiner, what answer you usually expect from the students? First
The
thing is to pass.
WPW syndrome, mainly patient with atrial fibrillation, some drug is contraindicated like any AV blocking. Otherwise, we can use any drug. So the question, what are the drugs we can, because AV blocking agent block the mechanism of tachycardia only with. So In that case, we cannot use any AB blocking agent. We can use the amiodarone, procainamide, something like that. So otherwise, we can use any sort of drug.
But amiodarone also, that is AV blocking agent, AV nodal blocking agent also. That also reduce the AV nodal conduction. What about beta blocker?
You can use
Beta
that.
blocker also reduce the atrial fibrillation.
So if the patient does
Doctor,
use it, otherwise we can use the beta blocker. Only is atrial fibrillation.
Dr.
So
Dhiman,
for
you are you-
examination purpose, what should our students say?
Exactly, sir, madam. What's the student, how to pass? What answer would be helpful to pass in the exam? That is most important.
Exam, the examiner considered that they have তাদের মাথায় থাকে যে কোনটা ডিগক্সি ভ্যারাপেমিল এগুলো দেওয়া যাবে না, সো এটা উত্তর সেভাবে দিতে হবে।
Exactly.
এটা কোনো ডাইরেক্ট কোনো আনসার নাই, যে ইজি আনসার না। তাকে বলতে হবে যে স্যার যদি এটা ন্যারো কমপ্লেক্স টাইকার্ডিয়া হয় এটা কন্ট্রাইন্ডিকেট, যদি তার প্রি এক্সিস্টিং আর্টেরিয়াল ফিব্রিলেশন থাকে তাহলে এটা কন্ট্রাইন্ডিকেট। এমন কোনো সিঙ্গেল আনসার নাই এই কোশ্চেনের যে দিস ড্রাগস আর কন্ট্রাইন্ডিকেট ডাব্লিউটা সিনড্রোম। দ্যার ইজ নট এ সিঙ্গেল আনসার অফ দিস কোশ্চেন। তো সেখানে তাকে ভাগ করে বলতে হবে যে এই কন্ডিশনে এই ড্রাগ কন্ট্রাইন্ডিকেটেড। আমার মনে হয় সেটাই বেটার আনসার হবে। তো
স্যার এখানে কনসেপ্ট তো ক্লিয়ার, একদম কনসেপ্ট ক্লিয়ার থাকতে হবে যে
হ্যাঁ বলো।
স্যার
হুম,
মানে এখানে তো কনসেপশন ক্লিয়ার থাকতে হবে একদম, যে আমি কোথায় দিব কোথায় দিব না। ন্যারো কমপ্লেক্স ইউ ক্যান ইউজ অল দি ড্রাগস ইনক্লুডিং বিটা ব্লকার, ক্যালসিয়াম চ্যানেল ব্লকার or other antiarrhythmic drug. If wide complex, you are confused whether patient having bypass tract or pre-existing bundle branch block, in that case we should have precautions regarding the use of the drug. সেই সব ক্ষেত্রে আমরা আদার যে ড্রাগ আছে, প্রোকাইনামাইড আছে, ফ্লিকানাইড আছে, আমরা ওগুলো ব্যবহার করতে পারি। আমি অ্যামাইডন আছে, খুব ব্রড স্পেকট্রাম আমরা ব্যবহার করতে পারি। হ্যাঁ,
এসব একটু অ্যাড তো মেইনলি হোয়াইট কমপ্লেক্স এখানকে সাদা যেটা জিজ্ঞাসা খুব আদারওয়াইজ ঠিক।
ওকে,
আর একটা কমন কোশ্চেন নেক্সট ভাই, যে what are the types of VT with narrow complex? Narrow complex.
ইউজুয়ালি ফেসিকুলার ভিটি আর ভিটি যে যেগুলো সেগুলো সাথে ইউজুয়ালি ন্যারো কমপ্লেক্স হয়।
Usually not narrow. You can measure because patient has a right bundle branch block, so it is not like narrow, but it is not narrow.
Yeah,
But less than 150 millisecond.
less than 150.
It is
And another is the very, I think proximal septal VT, very proximal to the AV node. That VT looks like narrow QRS complex.
একটা প্রশ্ন আমার তরফ থেকে আছে, আমাদের প্যানেলিস্টদের কাছে, সেটা হচ্ছে যে sometimes there is a difficult condition. Patients presents with episodic palpitation, severe palpitation, episodic, maybe once monthly, once every 6 months, or one every 2 months. Among patient becomes 6. We may suspect it may be SBD, but যখন সে ECG করে ECG নর্মাল আসে, হল্টার মনিটরিং নর্মাল আসছে, ECG তে কোনো বাইপাস ট্র্যাক্টর এভিডেন্স নাই, ইকো নর্মাল, but all suspicion goes for a supraventricular tachycardia. আমাদের দেশে লুপ রেকর্ডারও নাই যে আমরা লুপ রেকর্ডার দিয়ে রিপোর্ট। সেক্ষেত্রে what might be the way to diagnose this type of patient who are coming with episodes of palpitation which we cannot diagnose by ECG or Holter or any other? সেখানে কি আমরা বলবো যে go for an EP, or we should just এমনি ম্যানেজমেন্ট একটা রেট লিমিটিং ড্রাগ দিয়ে ছেড়ে দিই?
এটার ব্যাপারে স্যার আমি একটু কমেন্ট করতে চাই। আমি এখন সহজভাবে যেটা বলি, একটা ডিজিটাল অক্সিমিটার যেটা আছে, পোর্টেবল অক্সিমিটার যেটা বলে 1500 টাকা হলে পাওয়া যায়। আমি বলি এটা দিয়ে অ্যাটলিস্ট পালসটা মাপা যায়, কিন্তু 120-30 হলেও কিন্তু পালস রেগুলারলি ওঠে। সো এপিসোডিক হলে আমি বলি এটা দিয়ে ওই সময় পালসটা দেখবেন কত থাকে। অনেক রোগী বলে স্যার 195 এরকম থাকে, ডেফিনেটলি দ্যাট ইজ নট এসপিডি। আরেকটা হয় paroxysmal atrial fibrillation may produce the symptoms like paroxysmal SBD. So it is difficult to differentiate between paroxysmal atrial fibrillation from SBD.
আর এটা কমন ইনঅ্যাপ্রোপ্রিয়েট সাইনাস ট্যাকিকার্ডিয়া, এটা বেশ কমন, স্পেশালি ফিমেল পপুলেশনে এটা বেশ কমন।
Any comment from Professor Mohsin?
দাদা আমি যেটা করি বলি যে যেটা 1 ঘন্টার মতো সময় থাকে কোনো কোথাও থেকে কোনো ইসিজি করতে পারে তখন ডায়াগনোস করা যাবে। আর যদি
পেশেন্ট তো থাকে না, থাকে তো 10 মিনিট 5 মিনিট, খুব বেশি হলে 5 মিনিট থাকে না।
ভেরি ডিফিকাল্ট টু ডায়াগনোস।
আচ্ছা, আমি ডক্টর মোহসেন প্রশ্ন করি যে why you are not having loop recorder yet in বাংলাদেশ? বাংলাদেশে এখনো লুপ রেকর্ডার কেন আসছে না, বা এটার লিমিটেশনটা কোথায় একটু আমাদের এক্সপ্লেইন করবেন?
স্যার ইট ইজ নট
Why it is not available in Bangladesh?
আপনার স্যার যাই পেস দিলু স্যার কিন্তু উই ক্যান ডায়াগনোস হ্যাঁ আপনার
এটা
রিপোর্ট।
এটা
So this is the main reason. So not cost effective. That is the main reason. But it is a very important tool for the diagnosis of this. Mainly syncope, not
স্যার আমার পার্সোনাল অপিনিয়ন স্যার, এটা মহসিন যেটা বললেন যে কস্ট ইফেক্টিভ না, কমার্শিয়ালি যারা আনবে তাদের জন্য বেনিফিটেড হবে না। একটাই যে একাডেমিক্যালি যেসব হসপিটালগুলো আছে, যেমন আমাদের হসপিটাল আছে, এনআইসিপিডি আছে, অন্যান্য হসপিটাল, এই হসপিটালগুলো এটাকে প্রমোট করতে পারে স্যার। লুপ রেকর্ডার
এটার অল্টারনেট স্যার একটা বদিউজ্জামান স্যার, বস্টনের একটা অল্টারনেট আছে যেটা বাইরে এক্সটার্নালি এটা সেট করা যায়, অনলি লিড 2 ক্যান বি রেকর্ডেড ওভার এ পিরিয়ড অফ 7 ডেজ। এটা আমি একটা পেশেন্টের করেছি এবং 6 সাইনাস 12 বা 24 আওয়ার্স 48 আওয়ার্স Holter monitoring, I did not get any significant pause.
7 days পর্যন্ত করা যায়, 7 to 15 days পর্যন্ত করা যায়।
স্যার এখন 30 দিন পর্যন্ত, স্যার এক মাস করা যায় স্যার এখন 1 মাস পর্যন্ত করা যায়। একটা কোম্পানি আছে স্যার, ওরা 1 মাস পর্যন্ত করতে পারে।
ওটাকে বলা হয় ইভেন্ট রেকর্ডার। ইভেন্ট রেকর্ডার বলা হয়। ইভেন্ট রেকর্ডারটা আসলে অনেক আগে থেকে ছিল, আমাদের সেই মাত্র আসছে। ইভেন্ট রেকর্ডার ইভেন এমন সিস্টেম আছে the patient, when the patient has got a switch তার হাতে, সে যখন symptom feel করবে, he presses the switch and doctors in the chamber, he got the notification that this patient has symptoms, and even the doctor from his chamber gets the ECG through net Wi-Fi. সুতরাং এটা এখন আছে মানে ইভেন্ট রেকর্ডারে। সো পেশেন্ট যখন সিম্পটম হবে, সে যখন বাটন প্রেস করবে, the physician will be alerted and the ECG will be transferred to the physician's desktop or laptop or স্মার্টফোন। So that's a good technology. এখন আমাদের দেশে এগুলো আসেনি। এনিওয়ে, আর কোনো প্রশ্ন? ডক্টর ধীমান বণিক, এনি কমেন্ট? ধীমান বণিক তো খুব এক্সপার্ট আমাদের পরীক্ষার্থীদের জন্য। ধীমান বণিক
আরেকটা পরীক্ষা স্লিপ করলে
কি জিজ্ঞেস করে?
স্যার একটা কোশ্চেন আছে যে প্রি এক্সাইটেশন সিনড্রোম যদি দেয় শর্ট নোট বা, তাহলে কোনটা কোন জিনিসটা টাচ করা লাগবে?
মানে
স্যার ভাই
হ্যাঁ, প্রি এক্সাইটেশন ভেরিয়েন্ট, হ্যাঁ
শর্ট নোট দেয় প্রি এক্সাইটেশন সিনড্রোম।
প্রি এক্সাইটেশন সিনড্রোম বলতে গেলে যে যখনই অ্যারিথমিয়া থাকবে তখন আমরা প্রি এক্সাইটেশন সিনড্রোম বলবো। আদারওয়াইজ কিন্তু প্রি এক্সাইটেশন ভেরিয়েন্ট ডব্লিউপিডব্লিউ প্যাটার্ন বলতে পারি আমরা। ডব্লিউপিডব্লিউ সিনড্রোম বলতে গেলে আমাকে অবশ্যই তাকে অ্যারিথমিয়া থাকতে হবে, আদারওয়াইজ আমি কখনোই সিনড্রোম বলবো না। আমি বলবো প্রি এক্সাইটেশন ভেরিয়েন্ট অথবা ডব্লিউপিডব্লিউ প্যাটার্ন। যদি আবার ফ্র্যাঙ্ক তার আছে কি বলে প্রি এক্সাইটেশন দেখা যাচ্ছে বাট কোনো অ্যারিথমিয়া নাই, প্রি এক্সাইটেশন ভেরিয়েন্ট অর ডব্লিউপি প্যাটার্ন।
না স্যার, প্রি এক্সাইটেশন সিনড্রোমের মধ্যে কি এলজিএল বা মাইন্স আসবে?
এলজিএল তো আসবে, তো আসবে
না?
আসবে এলজিএল।
তাহলে প্রি এক্সাইটেশন হলে ডব্লিউপিডব্লিউ লিখতে হবে, মাইন্স লিখতে হবে, সাথে
এলজিএল লিখতে হবে,
তাই না? এটা কিন্তু স্টুডেন্টরা কিন্তু এটা ক্লিয়ার হইতে হবে। আর একটা কোশ্চেন আছে নাসির ভাই যে ডব্লিউপিডব্লিউ
মাহিম
সিনড্রোম।
হ্যাঁ মোহসেন বলেন।
মোহসিন ভাই বলেন।
এক্সাইটেশন থাকতেও পারে, নাও পারে, or not. So it is যেটা so it is all with wide complex tachycardia. It is confused with ventricular tachycardia when they, so it is atrial tachycardia. So it is left bundle left থাকে, so always we have tachycardia.
ঠিক আছে, আমার
স্যার স্টুডেন্টদের জন্য স্যার স্টুডেন্টদের জন্য স্যার আমার একটা এলো যে আসলে ওদের পরীক্ষার যে 10 মিনিটের ভাইভাতে কখনোই এত বেশি ডিটেলস ওদের লাগে না, মেইনলি লাগে ইসিজি গুলো। দেখা যাচ্ছে ইসিজি ডায়াগনোস করতে পারে না। এর মধ্যে অ্যাট্রিয়াল ফিব্রিলেশন, অ্যাট্রিয়াল ফ্লাটার, কর্নিয়াল হার্ট ব্লক আর সাধারণত অ্যারিথমিয়ার মধ্যে এসবিটি আর ভেন্টিকুলার ট্যাকিকার্ডিয়া ইসিজি গুলো বেশি থাকে। এগুলোকে সম্বন্ধে এবং এগুলো রিলেটেড কোশ্চেনকে ওদের জানতে হবে। এটা আমার অবজারভেশন স্যার।
ওকে, ডক্টর অশোক কোনো কমেন্ট করবো, আমরা শেষ করবো।
Thank you, sir.
Concluding comment.
Good session, I think. This is a good session. I think lot of discussion, but for the students' exam purpose, they should make the thing very precise. Lot of things that all the things I think they don't need to know all the things. So they should concise it to very few points, and they should try to remember that few points. Thank you. Thank you.
Madam, any concluding remark about the session? Professor Fazila Malik, Madam Nai, পিসিয়াতে গেছে সেশনে এখন পিসিয়া। Okay, Madam is busy with her work, I think, intervention. So, Professor Mohsen Ahmed, any concluding remark before we finish the session?
স্যার আরেকটা প্রশ্ন জিজ্ঞাসা করে WW স্যার মাথায় থাকে 2-3 ABF is diagnosed as inferior MI, so it is called pseudo infraction.
Exactly. এটা খুবই ইম্পর্টেন্ট কথা, ভেরি ইম্পর্টেন্ট,
খুব কমন
এবং এটা সবচেয়ে ইম্পর্টেন্ট হচ্ছে যে ইভেন আরেকটা ইম্পর্টেন্ট কথা মনে করে যেত। থ্যাংক ইউ প্রফেসর মোহসেন, খুব ইম্পর্টেন্ট কথা বলেছেন যে পি এক্সটেনশন থাকলে অনেকে ইনফ্রামাই বা ডায়াগনোস করে 1 নম্বর। 2 নম্বর হচ্ছে পি এক্সটেনশন পেশেন্টকে ইটিটি তে পাঠালে, স্ট্রেস টেস্ট পাঠালে ফলস পজিটিভ আসে, এসটি ডিপ্রেশন, এসটি এলিভেশন আসে, এবং পেশেন্টকে বলা হয় যে পেশেন্টের চেস্ট পেইন নাই কিন্তু তার খুব মার্কস এসটি ডিপ্রেশন হয় ইন পেশেন্ট উইথ পি এক্সটেনশন সিনড্রোম, তাদের যদি স্ট্রেস টেস্ট করা হয়। এটা খুব ভালো কথা বলে, এবং I myself seen many patients who are diagnosed with infra-MI who are actually having pre-extension syndrome. Thank you very much for mentioning.
এগুলো স্যার বলা ইনফিএমআই টাইপ বলে স্যার, বলতে শুনছি আর কি অনেক আগের ইয়াদের। আর স্যার রিগার্ডিং ইটিটি স্যার, আমি পার্সোনালি যেটা করি যে রিস্ক স্ট্রাটিফিকেশনের জন্য, যে তার যদি ইটিটি করার পরে যদি তার প্রি-এক্সটেনশন চলে যায়, যে লো রিস্ক, নো নিড to send the patient for EP study. আমি পার্সোনালি আমার পেশেন্ট আমি এটা করি।
Thank you very much. I think Professor Fazila Malik is still busy with her work, so she's not available. Fazila, are you available there? No. Okay. Thank you. So thank you very much, Professor Mohsen Ahmed, for joining us and enlightening us with your knowledge, and Dr. Shaim Chaudhary and Dr. Mina Saadin Ahmed for your presentations. Dr. Ashok Datta, Dr. Dhiman Bonig, and all other, Dr. Tawfiq Shahir and other who are present here, Dr. Haibur Rahman. Thank you very much. And with that, we are concluding our session, and see you soon in the next our session. Thank you very much, and goodbye.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you very much.